Well, thank you very much for that kind introduction, Dr. Mackenzie. And thank you, everybody, for having me here today. It's an absolute pleasure to be here. What a beautiful campus. What a beautiful place. So I'm just so happy to be here. Thank you so much. So in the last 10 years, we have learned a lot about pediatric airway management. And I want to share some of what we've learned with you today. And no conflicts of interest, just some affiliations that you have heard that are very important and near and dear to me. And I want to take you to Switzerland, okay? And here we have this beautiful capital in Bern. And you see this beautiful river around the capital here, okay? The Air River. It took my attention right away. Gorgeous. Look at these clear waters. And my host there told me, well, this river, people swim in it. It's so clean that you can drink the water out of it. In fact, people on their way to work will jump into this river, swim to work, change when they come out, and walk right to work. I was just so impressed by this. And I'm like, wow, I want to try this river. And they said, sure. You know, you should absolutely try it, but pay attention, be careful, and follow the signs because you must get out. And I said, oh, you know, why must I get out? You know, what happens if I don't get out on time for the river? And, you know, I thought, scrape my knee, scab my elbow. And he said, no, you die. If you don't follow the signs, and pay attention and get out at the time that you're supposed to, you will die. This is what will happen. And this is what could happen to this baby, okay, who presents to you in distress, in need of your help, in need of airway management. If you don't pay attention to the subtleties and the signs and have a plan to safely take care of this baby could die. So what are you going to do? How are you going to help this patient? Are you going to intubate this patient? Are you going to provide some muscle relaxant to do so? Are you going to oxygenate this patient? How are you going to do it? Are you going to do it throughout? What are you going to use? What device? So I want to talk to you about three things today. Talk about the risk factors in children with difficult airways that increase complications. Talk about advantages of various indirect laryngoscopy techniques. And I want at the end of this for us to formulate a plan of how we're going to manage anesthetic depth and provide oxygenation when intubating a child with a difficult airway. So this is the river that I get in Philadelphia as I walk to work every day, the Schuylkill River. Okay, so I will not swim in this river, nor will I drink the water out of this river. But it is a nice, lovely walk as I get to the beautiful Children's Hospital, Philadelphia. Absolutely love CHOP. It's a great place, a wonderful place that takes great care of children. And it's amazing. We're lucky to do what we do every day, to be there for a child. And it's no joke that anesthesiologists have come to a lot of attention recently with, you know, everything that we've been through in this pandemic and all the airway management that we have provided. And anesthesiologist is on the cover of Time magazine. Airway management is important. You know, the world recognizes this, right? And more than ever now, right? We are so invaluable as the airway experts. And oftentimes people think that airway is about being good at using tools and devices such as the ones that you see here. But I want to challenge us to think about airway management about so much more than that, okay? Getting a tube in the right place is only a part of the job. The most important thing that we do as we do that is keep a patient alive and oxygenated as we do that, right? So devices are just a part of the airway puzzle, a very important part, but just a part. So when someone says to me, someone calls me and says, we're working together tomorrow and we have a difficult airway, and I go, great. I go, what's your plan? And they tell me fiber optic scope. I go, great. That is a device. That is not a plan. I want you to tell me a story. I want you to tell me about where the difficulty of this difficult airway lives. okay, and how you're going to manage that. What technique and devices are you going to use to overcome that difficulty? Okay, how are you going to maintain anesthetic depth throughout that intubation attempt? And how will you maintain this patient oxygenated? And so we all know here that the pediatric airway is a little different, right? It's not necessarily harder. It's just different. And there are some differences that we have to get used to and we become comfortable with to safely take care of these patients, right? So the most obvious is the larger occiput, right, in these patients. So that large occiput, that large head results in a natural state of flexion when your patient is sedated or when you induce anesthesia, right? So obstruction can happen very quickly, and some challenges with mask ventilation can happen because of this large tongue, which is normal for them, but it is disproportionately large compared to the rest of their oral pharynx, right? That's also important because if you don't appreciate that, you might not think to really sweep that tongue out of the way as you're performing a direct laryngoscopy technique. And that is very important. If you don't do that, you're not going to find what you're looking for. And about what you're looking for, well, it's so high in the airway, right? It's a lot more cephalad compared to an adult. So you don't need that much blade to get in. And these are the kinds of things I tell my trainees. It's very important to prepare yourself to understand what you are looking for in order to find it. Okay. And then the relationship between the glottis and epiglottis and that angle, right? So in an adult, it's pretty parallel compared to in a child where there's a bit of an acute angle, right? And this is often why people say, oh, pediatric airways are a little more anterior. They're more anterior. It's just a different relationship with those angulations that you just become used to. Okay. And after a while, it becomes a routine, seamless thing that you just do every day, right? But I'm talking about these airways. These are the difficult airways that we're taking care of. Okay. And so, yes, they come with some of those basic principles of pediatric airway management, right? But when you look at a patient like this, you should pause and say, wow, there's something different about you. There's a craniofacial difference that you come with that, kind of heightens my spidey sense that there might be some trouble here and that I should think twice about what I'm going to do. So Clyde Matava and I were talking about this for a couple of years. Like, what are the basic things? Like, the art of simplification, right? If we had to break it down, what are the basic things that you must do when you're taking care of really any airway, but especially the pediatric infant neonatal airway? Okay. And so, well, like I said, you're selecting a device and a technique based on where the difficulty lives. If you have a healthy infant, maybe you're, selecting a CMAC, standard blade CMAC. Okay, fine. You are deciding how you're going to manage anesthetic depth. And maybe, you decide that you're going to paralyze, and that's fine. You've taken care of that arm. Okay, you're not going to have airway reactivity occur during the intubation attempt. And you're going to oxygenate, maybe provide some nasal cannula throughout the intubation attempt. And human factors. Okay, always remember that human factors exist everywhere. Okay, we can't be doing the same thing over and over and expecting different results. We have to keep each other in check. We have to speak up. So when it comes to the devices and techniques, okay, we learned a lot from the Pediatric Difficult Intubation Registry, a multi-center quality improvement database that collects data on patients who are difficult to intubate. And all these patients get cataloged into the registry, and we learn about exposures, patient demographics, what their airway exam was like, whether they had a syndrome, yes or no, and what syndrome was that? What was the preoperative plan? What was the intended ventilation technique for that first intubation attempt and for the subsequent intubation attempts? And the case data, what happened? Was mask ventilation possible? What airway devices were used? What complications occurred? And these are the complications that we're talking about, okay? They're classified generally as non-severe complications and severe complications. Non-severe complications being things like laryngospasm, hypoxemia, bronchospasm, early recognition of an esophageal intubation. And then severe complications being more horrible things, right? A pneumothorax, severe airway trauma, delayed recognition of esophageal intubation, and cardiac arrest. And so when the pioneers of this registry were deciding on these complications, okay, and standardizing this, the question came, well, a little hypoxemia, What does that matter? So the baby desats to like 86 and you bag them up and then, you get the sats back up. What is the problem, right? And the problem is that hypoxemia is the pathway to cardiac arrest. And that's why it matters. So the first study that came out of the PD registry involved 13 sites at the time. This was in 2016. Over 1,000 patients were involved. And what was found was that direct laryngoscopy was the most frequently used device, okay? And indirect techniques were less frequently used. And the success rates were these, okay? Not too shocking, right? So people infrequently reached for indirect techniques. Quickly, it was learned that the smaller patients are at greater risk. Those less than 10 kilos have more complications. To limit intubation attempts, okay? Multiple attempts result in more complications. Like this. This patient had at least 7 attempts at their airway. And that, especially after 2 intubation attempts, the odds of complications increases significantly, about 1.5, okay, per each attempt. And that perseverance is not your friend, okay? If something's not working, you need to switch to something else quickly. When you stop, direct laryngoscopy matters. So an early transition compared to a late transition from direct laryngoscopy had fewer complications if you switched earlier compared to later. So that first study was summarized by this: those less than 10 kilos, more than 2 direct laryngoscopy attempts, also a short thyromental distance, and the persistence of direct laryngoscopy was associated with more complications. So the lesson really here is just begin with an indirect technique. Just begin with an indirect technique, okay? Especially if you know that this is going to be a difficult airway, if you suspect that. So when it comes to indirect techniques, this other study that came out of PD looked at glide scope compared to direct laryngoscopy for intubation of these difficult patients, right? Difficult airway patients. And then what was found was that the initial and the eventual success rate of the glide scope, here in blue, compared to direct laryngoscopy, was greater, okay? Across all patients, all pediatric patients. And now you notice here that even though it was greater glide scope compared to DL, the magnitude of that difference was a little bit less for patients less than 10 kilos, right? So you wonder, it's helpful, but why is it a little less helpful to them? And then this other study came out looking at intubation with a fiber optic scope via supraglottic airway compared to direct laryngoscopy, also in the PD registry. And what was found was that that technique was especially helpful in the smallest of patients, those less than 1 year, okay? And here's this technique. And people, do this differently. We like to use an AirQ LMA, load up the endotracheal tube beforehand, connect it to a bronchodapter, swivel peep keeper, inflate the cuff of the endotracheal tube, okay? And now that is all set to go. And place the supraglottic airway in the patient. And through this adapter, we can actually ventilate. So we've taken care of the oxygenation arm, and better yet, ventilation, okay? So now we can go ahead and enjoy our procedure. Take that fiber optic scope through the adapter, go ahead and find what we are looking for. And get to where we need to go. Now, very important with this technique, especially in a small patient, is to be able to keep the endotracheal tube in and take the supraglottic airway out without losing it, okay? And, here we've deflated the cuff of the endotracheal tube. We are passing it through. And in this case, I'm using laryngeal forceps to be able to control the tube. There are multiple ways of doing this. This is just my favorite way because I feel like you can just clip the endotracheal tube and it's not going to go anywhere. You can use, there are blue pushers. You could use another endotracheal tube, whatever helps you just have control of that tube on your way out. And there you go. Okay, so you can see why, this may be helpful in a young person, right? In someone less than 10 kilos, because you're oxygenating them, right? And we know these children consume more oxygen, right? So that might time you out from what you're trying to do with your intubation. So then what do we do with direct laryngoscopy? After seeing these data, should we just not use it at all, right? And some people will say, yes, thank you for showing these data. I understand. You like these indirect techniques, but I've got this. I am very good at direct laryngoscopy, okay? These indirect techniques, they're for people born after the 90s. And I understand, right? I too like to take notes. I too like to do things traditionally, Unlike my husband, who actually loves technology and will show me the latest app for everything all the time. So maybe there is a place for old technology, right? But when you get this baby, what are you going to do? You should be able to look at this baby and say, hey, look, there's something, you might not know the syndrome, but there's something different about you, okay? That heightens my awareness that you might be a difficult airway. So what about normal airways? I told you all these data about difficult airways. So what do the data say about normal airways? So initially, this Cochrane review was done in over 800 children, comparing direct laryngoscopy to video laryngoscopy, and found no difference in first attempt success, longer intubation time with VL compared to DL, and that perhaps the use of VL improved the percentage of glottic opening. And the authors of this review do disclose that the data quality was very low and that there was very serious heterogeneity. And what about in neonates? Another Cochrane review looking at a few RCTs and found that there was no significant difference in the time to intubation, no difference in time to desaturation, and perhaps an increase in first attempt success rate with VL. But again, very low quality evidence, some issues with heterogeneity. So why all the heterogeneity? They're comparing standard video laryngoscopy to non-standard video laryngoscopy, hyperangulated blades to non-hyperangulated blades. They pooled all these kinds of video laryngoscopes into one category, VL, okay? And we know that these two things are not the same, okay? They're both video laryngoscopes, but the technique that you need to use each one, particularly in the pediatric patient, is very different, okay? Jamie Payton looked at this, comparing standard blade VL to hyperangulated blade VL in children in the Pediatric Difficult Intubation Registry, and interestingly found that for those less than 5 kilos, standard blade was actually more successful than hyperangulated blades, okay? And there's a reason for that. Well, we wanted to, sort this out as best as we could. And so a group got together and decided to compare standard blade VL compared to direct laryngoscopy in those less than 12 months, healthy infants, less than 12 months, presenting for general anesthesia, okay, in 6 centers. And by standard blade VL, we mean something that if you cover the screen, you can perform direct laryngoscopy through. So your standard, Millers and Mac blades, not hyperangulated blades. And so, 2 different arms here. We had the VL group, we had the DL group. These were the sites that were involved. So Boston Children's, us, we had a site in Australia, Seattle, and Texas as well. And then the participants for the study were attendings, fellows, and residents. This was the median weight. And as you can see, it's balanced across both groups. And for the most part, we had, ASA 1s and 2s, so healthy infants. Okay. And we then had patients provided with muscle relaxant for the study because we didn't want airway reactivity, airway response to be different between the two arms and for that to be, accountable for the differences. And this is what we found. Video laryngoscopy compared to direct laryngoscopy had a higher first attempt success rate. And in the video laryngoscopy group, the incidence of severe complications was much lower compared to direct laryngoscopy. There were fewer esophageal intubations that occurred in the video laryngoscopy group as well. So a 5% improvement in first attempt success, fewer severe complications, fewer esophageal intubations. And interestingly, the need for external laryngeal manipulation, often known as cricoid pressure, was reduced in the video laryngoscopy group, okay, compared to the direct laryngoscopy group. Nothing new, right? This has been studied in the neonatal setting as well. So with pediatric residents, Dr. O'Shea noted that the success rates of junior doctors had fallen to less than 50%, okay, on that first tracheal intubation attempt. But when the instructor is able to share their view on a screen, that success rate increases significantly. So back to the VISI trial, when you look at the data a little bit closer, you see that in those patients less than 6.5 kilos, the magnitude of that difference that we found, the 5% improvement in first attempt success, is actually a 12% improvement in first attempt success. So this matters the most in the smallest, most vulnerable of patients. So we did the math. And if 1.5 million infants have surgery and 500,000 of these require intubations, and we improve first attempt success rate from 88% to 93%, we can potentially prevent 10,500 esophageal intubations, fewer opportunities for respiration, 10,500 fewer opportunities for cardiac arrest, and fewer opportunities for neurologic injury. So this is a big deal. And remember that this was looked at in the operating room setting where we perform intubations routinely. Imagine this outside of the operating room. And so I have my 3 children here, and I can't help but think about them every time I'm taking care of a baby. Okay. I ask myself, if this were my baby, what do I want you to do? Would I want you to do direct laryngoscopy or this? And notice that this is a straight blade, a standard blade, and that the tip of the blade is in the vallecula. Okay, so whenever possible, I do encourage using it that way. It'll leave you the most lumen for your airway to fit that tiny tube, the biggest possible appropriately sized tiny tube that you can. So what about maintenance of anesthetic depth? Okay, so how should we do it? So let's play a game. And the game is called, would you paralyze this patient? Okay, so don't be shy. Would you paralyze this patient? Look at this airway. Who would paralyze this patient? Yeah, sure, right? It's a pretty good airway exam, right, Dr. McKenzie? Looks pretty good, right? Yeah. What about this airway? Would you paralyze this patient? What does this child have? What do you think about those tonsils? Almost kissing, right? Yeah. Okay, but we could paralyze this patient, right? Be prepared that obstruction might happen on induction. But, yeah, we can paralyze this patient. What about this cute little guy? Yeah, healthy infant, mask induction, get your IV, paralyzed, sure. What about this guy? No, there's something different about this guy, right? What does this patient have? What do you think he has? Turner sounds, yeah, close. Klippel, yeah. So this is an airway I would be careful with. What about this one? What do you notice immediately about this patient? Yes, if you're pointing to the mandible, does it exist? Is it there? Okay, yeah. Severe micrognathia and retrognathia in this patient, okay? And that's this patient. What about this airway that comes to you in the middle of the night that has something in it? Would anybody do this with neuromuscular blockade? And you can see we're struggling to get this out, whatever this is. Can you tell what it is? Peanut close. That's usually one of the common ones. What was that back there? Penny? Popcorn. I don't know. This is why when we make popcorn, I just don't give the bowl to my kids, because you never know what's at the bottom. And, this is what this poor little child has in their airway. So this is a tough one, right? Because, of course, they're a full stomach by definition, right? Yet we want ENT to go ahead and get this out. And it can take this long to get this out. Look how long this is taking and how much they're struggling. And this is real. This has like a ball valve mechanism, right? So it just keeps going back. And we don't want to have full airway obstruction. At the same time, we need to keep the patient breathing and alive and oxygenated. So a spontaneous ventilation technique would be very helpful. However, we have to figure out how to calm down airway response, right? Because if this patient reacts, coughs, suddenly this item can get dislodged more. So getting the right intubation conditions, that's another very important component of airway management that sometimes it's often overlooked, right? Like we think about getting the tube in the right place. There's all these data about the devices and the technique, and we focus on that, and then we just give a little something and then go, right? But I challenge us to think about airway management and anesthetic depth in particular, that arm of airway management, as a dynamic process. Okay, so it's not just a one-time dose and go, but it's thinking about the steps that you need to do to get into the airway and the anesthetic depth required for each of those steps. So perhaps I might want to place a modified NP airway in someone, and the anesthetic depth required to do that is very different than the anesthetic depth that I need to get a fiber optic scope across the court, into the court, right? So this perfecting this moment is, can be everything, can make the difference between a not such bad airway, turn into a horrible airway. And so people have discussed this in the past. So like, how do we grade intubation conditions, intubation readiness? And then there was a group that has met over and over actually, and got together to talk about, well, how do we, standardize this, not just clinically, but also for research studies? Like, what are the things that we are evaluating when we're looking at intubation readiness? And they decided, well, these three things: laryngoscopy, okay, the response to laryngoscopy, vocal cord position, and the patient's reaction to placement of the tracheal tube, right? And then if you meet all those criteria, you don't, and they define this like as a relaxed jaw, whether the patient has a motor response or not, you would be in the category of clinically acceptable, excellent conditions, versus if the patient, had a plantar flexion response, right? That might put them in the not clinically acceptable, because it's suggestive that once you insert the blade, the same or worse will happen, especially in a reactive airway, which the pediatric airway is by definition, right? So then why don't we just paralyze everybody, And it's not generally because of the risk of allergic reactions or myalgias or awareness of under anesthesia, because that's pretty rare. It's because we're worried about these two guys. Right? We're worried that we might start off with an airway that's perfectly fine, okay? And that now we provide neuromuscular blockade, and that inherent airway tone that the patient had that was stenting their airway open now totally collapses. And now we can't ventilate, and we get into this horrible can't intubate, can't ventilate situation, right? In someone who consumes a lot of oxygen and can quickly arrest. So this guy reminded me of that situation. I was called to assist in the ICU with this patient's intubation. He had been extubated, but unfortunately, he was in quite distress, and he had about 7 intubation attempts. And this is what he looked like during each attempt. So then you have to make a pretty dangerous decision here. You have to decide, well, first of all, what can I optimize, right? So, provide some oxygenation throughout, et cetera. And then B, what is the problem? Where does the difficulty of this airway live? Is it really the exposure, or is it the anesthetic depth that is preventing the intubation from happening? And so I paralyzed this patient, got good exposure with the CMAC, and intubated. But it's a tough choice, right? And what do the data show about muscle relaxants in pediatric patients? That, well, generally speaking, about half or a little more are done without muscle relaxant. And then data from 10 neonatal ICUs show us that 53% are done with no neuromuscular blockade, but the complications are so much greater when neuromuscular blockade is not used. Additional data from a single site here, showing that generally speaking, neuromuscular blockade is not used as much. And when it is used, non-depolarizing agents are used. So we wanted to explore this a little further and ask the question, well, does paralysis help? What is the impact of neuromuscular blockade in children with difficult airways? And we looked at this in the PD registry and looked at anticipated difficult airways, because we would be able to see the initial plan, whether they were intubated with spontaneous ventilation, controlled ventilation with muscle relaxant, or controlled ventilation without muscle relaxant. Again, looking at the same complications that we defined earlier, and found that those with spontaneous ventilation have more complications compared to those that were intubated with muscle relaxant or controlled without muscle relaxant. So that was interesting, because that's not what we expected to find. We were like, really? Doesn't traditional anesthesia teaching tell us to keep a patient spontaneously breathing, because that's the bridge back in case you can't intubate them? So why are we seeing complications with the spontaneously ventilating group more frequently? And, sometimes things are not as they seem, right? So this is where, your research hat has to go in and be like, is this really true, right? I can't get much causal inference, but, right? But is this reality, or is there something else going on? Yes, parents during the pandemic hiding from their children. So we did a multivariable logistic regression where we adjusted for factors like age, gender, weight, syndromic status, abnormal physical exam, who was the clinician intubating them, the device that was used, et cetera. And also decided to do propensity score matching. So not just, syndromic, yes, no, but what was the syndrome? Not just abnormal airway exam, yes, no, but where was that abnormality? Where does it live, right? Fused neck, no mouth opening, et cetera. And we matched based on these factors and still found that spontaneous ventilation has more complications compared to the other techniques. But why? Why? And when we look at this closer, you see that with spontaneous ventilation, the more common complications are hypoxemia and laryngospasm. And this is that vicious pathway that we're trying to avoid, right? Hypoxemia, laryngospasm, big desaturation, bradycardia, cardiac arrest, right? But then when you look at this a little closer, I became, pretty obsessed with this, because I'm like, oh, there's something else happening here. And when you look at it, you see that even though spontaneous ventilation has more complications compared to the other two techniques, controlled with muscle relaxant and controlled without muscle relaxant have the same lower rate of complications. So is the muscle relaxant making a difference, right? Perhaps patients with spontaneous ventilation have reduced anesthetic depth. Understandably, we don't want to lose that bridge, right? We don't want to overdo it, which then leads to more airway response, which then leads to more complications. And we were able to capture this. We were able to capture whether the patient had airway reactivity, yes or no, in the registry, and found that spontaneously ventilating patients have increased airway reactivity, and patients with increased airway reactivity have more complications. So airway response is mediating the relationship between spontaneous ventilation and complications, okay? And another way to further test this, right, is to look at what happens with the combined technique, where you have more intubation attempts with that technique, which is more complicated and takes longer. So combined technique where you're using a video laryngoscope and a fiber optic scope at the same time. This is especially challenging to do. By the time you're reaching for this, you probably have a very bad, difficult airway. And it's challenging to do in children who consume a lot of oxygen and don't give you that much time, right? So why is maintaining appropriate sedation with spontaneous ventilation so challenging? when we talk to our adult colleagues, they'll say, well, just tell the patient, hold on, and go topicalize their airway and just do this awake. But it's very difficult to do that in children because they're not very cooperative. Then you're starting to give a little sedation, a little more, and now that is no longer an awake intubation. Okay. So sedation is a continuum that is difficult to establish in children. We might have differences in what we consider appropriate levels of sedation amongst ourselves. And it's not a technique that is as frequently used as general anesthesia in children. Okay. And then this study looking at sedation versus general anesthesia for children with difficult intubations from the PD registry found that 27% of sedation cases needed to be converted to general anesthesia in order to complete the tracheal intubation. Now we're talking about 50 sites across the world who specialize in pediatric airways, right? And even these experts, right, under the supervision of these experts, this is still so challenging, right? And so people will say, well, so what's your thing? Like, how do you decide that you're going to paralyze somebody or not? And I ask myself these questions, and whether I'm going to do this more on the sedated versus general anesthesia side. Is ventilation expected to be difficult? And is access to the oral cavity and/or upper airway blocked by something? Okay. And if the answer to these two questions are no, I'm more likely to provide neuromuscular blockade. There are many options for sedation in pediatric patients. Really, you can use a lot of things, right? But you have to keep in mind the synergisms between medications, because sometimes people say, I'll just use a little Precedex, but you're using a little Precedex after a little ketamine, after a little midazolam, and now there are synergisms between these drugs, and now you can stop that patient from breathing, okay? So some commonly used choices here. Another one that we should add here is the combination of propofol, remifentanil. Okay, low dose remifentanil infusion and propofol, assessing your anesthetic depth throughout can get you right through an MLB in a child, right? And then airway topicalization. I like to nebulize the airway. I like to provide nebulized lidocaine. And I feel like I get the most bang for my buck with that in children, after I give them some midazolam premedicant. And we're looking at this. We're looking at, we're starting the study looking at what we can use as a litmus test to assess intubation readiness. So, we have, our sort of pregame plan of like, okay, here are the general recipes and cocktails that we'll use, but what can we actually use to test, okay, we've given what we've wanted and now the moment is right to intubate. And I like using the maneuver that the good Dr. Philip Larson, right here from Stanford, coined in the 90s, the Larson maneuver, right? And so Dr. Philip Larson coined this Larson maneuver where you take your fingers and you bring the jaw forward, providing inward pressure, consistent inward pressure, but at the styloid of the mandible, the topmost part of the mandible behind the tragus of the ear, not at the angle. And if you put your two fingers at the angle of the mandible, not too annoying. But if you put your two fingers behind the tragus of the ear and push, that is annoying, right? So Dr. Larson felt that, sedation, the issue with laryngospasm is because you have an imbalance between sedation and stimulation, okay? And so a patient in laryngospasm is probably light by definition for whatever stimulus that's going on, and that could be their own secretions. So if you push here and bring the mandible forward in a patient like that and they're light, they're probably gonna go, and that's exactly what you want them to do, to break the laryngospasm when you do this right. So if that can be used to potentially break laryngospasm, it could potentially be used to tell you that a patient is too light before you put that blade in, right? So that's what I like to do. Oxygenation, another lost child of airway management, right? Oxygenation should be the standard of care during prolonged tracheal intubation. The great Dr. Lippmann knew this already, okay, and taught this to us, right? And Dr. Fiaggio. And then Thomas Riva and friends looked at this thrive in pediatric patients once it came out in adults, right? When we were talking about this idea, I remember talking to our group and they were like, you want us to provide how many liters of what to this baby? You're out of your mind. I'm not doing that, right? Thomas looked at this across a wide age range of pediatric patients and actually found that both Thrive and conventional oxygenation were superior to not providing any oxygenation during the intubation attempt. But conventional oxygenation in this study was just as good as Thrive. Fine. And then we had the friendly argument of, first attempt success. Is it improved by VL? Is it really VL, or is it the fact that, the exposure, or is it that people run out of time and that oxygenation should be applied? That's what the European group felt, that oxygenation was more of a problem, because in their nectarine and apricot studies, they didn't find too many troubles with exposure of the glottis, okay? But they did have multiple attempts. So then Thomas decided, okay, well, let's do Visi, but in patients that are 3 months of age and smaller, okay? And then let's give them oxygen, both arms. And then let's see if VL actually still wins. And it still did. But his study also suggested that maybe the oxygenation arm was doing something. This was looked at as well in the NICU setting by Dr. Hodgson. And what they found here was that whether you use VL or DL, when you applied oxygen, you had greater first attempt success. And notice that their first attempt success was overall pretty low, right? And the authors of the study provided this video to the New England Journal, where this baby who was just born is about to be intubated and has oxygen applied. Okay, and this pediatrics resident is about to intubate using direct laryngoscopy. And you can see the baby's vitals up here in the top right corner. And you see the baby's saturations. And so far, so good, right? And those of us that do this routinely are like, I can see the smile there. We're kind of getting antsy. We're kind of like, all right, just please put the tube in the right place already. Come on, this is taking really long. But look, the baby's doing so well, right? With this simple thing that we learned in medical school, oxygen. Oxygen is good. Oxygen keeps patients alive. And look, still okay, still tube not in. And it's kind of like, put this tube in before now I start to die. And I won't belabor this. Eventually the tube goes in, okay? And the patient's oxygenation was generally maintained, okay? This study was in the Pediatric Anesthesia article of the day a couple of weeks ago, where a meta-analysis was done by this group looking at, well, is supplemental oxygenation the thing to do? And found that generally that was very favorable. But some questions arose from this. What are the flow rates? Where should oxygen be applied? Okay. And what patients benefit from this the most? Can we do this in cardiac kids? Here are those questions. And then the good news is that for now, you can take simple things that are around you every day to provide oxygenation. Okay. Taking like an NP Airway, modifying it with a 50 millimeter connector of an endotracheal tube. You can put that in the nair. You can provide oxygenation that way as someone does a nasal fiber optic, right? And buy yourself time. A hook in the mouth for MLBs, take a suction catheter, okay? Cut the tube a little bit and take that 50 millimeter connector out, hook that up, corner of the mouth, put it on your oxygenation flow rate, and there you go. You buy time. And of course, with this technique, you provide oxygenation and ventilation. So let's put this all together real quick. So here's your patient. She's 14 years old. She has geliophasic dysplasia, worsening dyspnea on exertion, now requiring 1 liter of oxygen, and has some stridor. And ENT says, we just need to do a quick look, quick MLB, okay? This add-on, help me out, just do it. What do you think? Trust but verify, for sure, for sure. Geliophasic dysplasia. Yep, I had to look that up too, exactly. Geliophasic dysplasia is a mucopolysaccharidosis. It's very important when we get these odd syndromes to go ahead, take a moment and look them up and see what's up here, okay? Because in a patient like this, if you induce general anesthesia, you might kill them, okay? Spontaneous ventilation is a must for these patients. They become rock hard to ventilate, even when they receive a little bit of sedation. So taking your time with this airway is key, right? So you have to tell your colleagues, your ENT colleagues, be around and help me out. Have a seat if you'd like, okay? But this is gonna take a while, right? So you go ahead, my approach was giving a little bit of oral midazolam, getting that patient to not care about an IV, going in, topicalizing the airway with inhaled lidocaine until she said, my tongue feels numb. And I said, great, okay? and then begin your sedation very lightly, right? It's hard. If I could do this awake, amazing, but she's not going to let me. She's totally refusing and freaking out, right? But keep it clean. Midazolam, Presidex, until she doesn't care for a modified NP airway to go into her nose, okay? Because my first approach for this airway is not getting the tube in. It's how can I establish an oxygenation conduit throughout to maintain safety, okay? That's step one, right? And then continue to follow step 6 as long as ventilation is possible. You can start augmenting the sedative level, okay? Propofol infusion in the background. Test your anesthetic depth before driving your fiber optic scope, okay? And be ready to augment that anesthetic depth right before going through the cord, because this is what her airway looked like, okay? And no anaphylaxis, no angioedema. This is just what she looks like, with 14 years of glycosaminoglycan deposition in her airway and everywhere else, by the way, to liver, lung, heart, etc. All right. And this is what we're trying to navigate ourselves through. And look at how easy it could be to lose this airway. So spontaneous ventilation is challenging, but often a necessary technique. You need to understand the difficulty of where your difficult airway lives and plan and strategize based on that, and take your time whenever possible to perform these maneuvers. Human factors matter. We have to help each other out. Take care of each other. We're in this together. But we must keep each other in check, because we are all human. And we do, and we need to keep each other in check. We need to rehearse. We need to practice. Someone told me that the best players are not the players who play more. They're the players who rehearse more, okay? So I want us to establish a culture of rehearsing airway management, developing these airway labs and these other great sessions like Dr. McKenzie had this weekend, where we rehearse these techniques. And now we master the technique, now 10 more, now faster. That's what airway management should be like, so that we can safely take care of these patients. Bring your residents, bring your fellows, bring your colleague in between cases, and let's go ahead and do some drills. Okay, and there they go. Because when you have this airway, this critical moment of truth, what you need to do needs to be built into your muscle memory. It needs to be the norm that you know how to do every day, not your freak out moment that you're doing for the first time, to keep this baby safe in the first attempt. So here's what we learned. Okay, multiple tracheal intubation attempts increase complications. You have a difficult pediatric airway, begin with an indirect laryngoscopy technique. Okay, standard blade VL, pretty helpful. Know your blade types, standard blade versus non-standard blades, big difference. Okay, different technique between the two. Standard blade VL may be more effective compared to non-standard blades in children less than 5 kilos. And we'll explore that more at another time. All right, and anesthetic depth matters. Really matters in pediatric patients. And make sure that you don't forget the lost child of oxygenation. Very important too. These 3 things plus human factors will keep your patients safe every time. And yes, I teach my kids CPR early on. Okay. And of course, the little one is the one running the code. Thank you so much for your time. I really appreciate your time and attention. And please let me know if you have any questions.
Any questions from the audience?
Hi. Thank you.
As soon as you had that date up there, I was like, well, that must be because there's selection bias. The more difficult cases are being chosen to have spontaneous ventilation, and then you did the propensity analysis, which, are you still sure that it's not selection bias?
You're right. There can be still a component of selection bias. We tried to control as much as we could, with multivariable logistic regression, propensity score matching, try to clean up the data as much as possible. But you're right. There's no way to truly know in this retrospective study exactly why an anesthesiologist chose one technique versus the other. But this was suggestive that, perhaps there's a problem with anesthetic depth that we should explore further. Thank you.
Annery, great talk. Can you speak a bit of cricoid pressure and some in the emergency room in particular, getting away from that to some degree? Some of the videos you had, there was, and others there was not. What's your take on that?
Cricoid pressure for like full stomach type of situation or for helping to expose the larynx? For both. Yeah, so thankfully with the use of VL now and the shared view of the screen, when it comes to exposure, I find that people are using less cricoid, less external laryngeal manipulation. And then when it comes to, and also on the other hand, when you see that your trainee needs it based on what you're seeing that they're struggling with, you can provide it when you need it, right? And when it comes to using cricoid pressure officially for full stomach precautions, at least in our practice, we're not really doing that anymore. We find that that probably disrupts the view more. And only when someone says, okay, give me cricoid, then we provide it.
Thanks, Annery, for a great talk. I have a quick question about methodology, because hypoxemia is obviously one of the biggest clinical outcomes here. How is that actually being defined as a data variable? And then is it reporter, whoever the anesthesiologist was, saying, yes, we had hypoxemia, or is that data mined retrospectively?
Yes, thank you. Great question. So hypoxemia was defined as greater than 10% drop in their baseline. Okay. And in this particular study, there were few patients with cyanotic congenital heart disease, but based on knowing the baseline that they come in with and a greater than 10% drop being like, mild hypoxemia and a greater than 20% drop being severe hypoxemia. Okay. And going forward, we're trying to sort of keep that definition. And then as far as how that was done, thankfully, data mine, Epic and actually reviewing the vital signs. And for greater than a minute, by the way, that was also defined. So it was easier to pick it up from Epic that way. Thank you.
So there were some questions for people watching remotely. Are there any intubation situations which you only attempt to do in the operating room, and why?
Yes. And there are actually studies looking at these data. And generally, they're finding that the intubations occur more safely in the operating room. So when we get the classic phone call, this NICU baby is in need of immediate intubation, and there's a little time to plan and to formulate and get ENT involved too. It's best to bring the baby to the operating room and do this in our environment. Okay. And have ENT have the setup for, a rigid bronch if they need, ready to go. If you have the, ability to do that, that is better.
There are also some questions related to the use of muscle relaxants. For the staged airway management using the supraglottic airway, it looks like for some patient populations, you would place it awake in a particular, with the patient breathe, not in the wake, but patient breathing spontaneously.
Sure.
And in other patients, you would breathe it with the patient anesthetized and paralyzed. So for the patients who breathe spontaneously, would you, once the supraglottic airway is in place and you fiber optically confirm that it's in a good position, would you paralyze the patient at that point for placing the tube?
Most likely, yes.
Okay.
So as soon, and this is what I mean by like augmentation of anesthetic depth. So initially pretty light until you're like, I'm almost there. And right before I make the big move, usually either neuromuscular blockade or a nice bolus of propofol to just make sure we don't ruin that very delicate moment.
Do you see any use for smaller dose of muscle relaxants instead of the regular intubating dose of muscle relaxants in pediatric patient population?
Yeah, no, smaller dose only for maintenance of neuromuscular blockade for the case, but usually I am giving the actual induction dose of the muscle relaxant.
And the other question was whether there were any tricks that you might have learned from your ENT colleagues for pediatric airway management in general and for the flexible fiber optic exam in particular.
Oh, so we need to carve that out a little more. So yes, ENT has shown us some tricks and tips with, we all share airway management discussion, but with that preoperative endoscopic exam, we really have not looked at much data on that in the pediatric airway world. And that I think is next. That is important. That could help us. Yeah. And then back to the neuromuscular blockade and smaller doses versus higher doses. I think part of the premise for that is the volume of distribution of these patients and the kinetics of the drugs. So if you give a smaller dose, you might not quite get the effect that you want at that moment, when you need it.
There is one more question just came in. Have you protocolized preparation of the operating room and all the personnel involved if you have a difficult airway? And if yes, what kind of standards you have instituted? And is it a formal, I guess the question, is it a formal protocol that is available for everyone to review also in the operating room? Do you have printouts available? How do you keep people, adherent
Alert.
to the protocols if they're in place?
Absolutely. I think that is very important, especially when it comes to human factors, right? And the fact that this is a team sport and that we are not doing this alone, right? And our nurses actually will tell us that they appreciate being involved and being given a job, a role during airway management. So we do have a thing called anesthesia now at CHOP. And anytime that there's a situation, whether it's, anaphylaxis or something else, difficult airway being one of them, that algorithm gets pulled up and it's displayed on all the screens so that everybody can see, but better in the operating room. Okay. So that everyone can see, okay, this is a difficult airway. Here are the things. We have a difficult airway cart, which is actually in many of the hallways. We have at least 4 of them across the 21 operating rooms. But when we have a difficult airway, usually that cart will come with. People will just order that cart to come in and the nurses know what's in there, But even a step beyond that, our ICUs, when they go ahead and have even a elective, semi-elective intubation performed, they have this beautiful timeout that they use, okay? Where everyone, people will pause and say, hey, this is a difficult airway. This is who I am. This is what we're going to do and why. This is why this patient is difficult. And here's our backup strategy and who to call. And I thought that is genius. And when we have difficult airway, these elective difficult intubations that we have to do, we should be doing the same thing in the operating room, the DAT, difficult airway timeout. And just like our surgeons will say, timeout, we're about to, antibiotics in, et cetera. We should be like, timeout. This is a difficult airway. I am so-and-so, and this is what I'm going to do. Here are my people. Here are the things. Here's the next step. And here's who to call. Because that could potentially provide greater safety for our patients. So we're going to look at that more.
Great question, just came in. So given the data that you presented on the advantages and better performance of video laryngoscopy, are you mandating now for your colleagues to use video laryngoscopy, at least in patients under 3 months old?
That's a great question. I love that question. That comes up a lot, actually. So what we've got going right now is that for any intubation on a person who is 12 months old or less, the CMAC is by default brought to the operating room. So our anesthesia techs will know to set that up. Now, of course, paired with that, the question comes, oh no, trainees are not going to know how to do DL because there's all this VL coming up, right? And in fact, people can, lose their skills or leave residency not knowing how to do that. Worry not, I've got you, okay? Because what happens is you can use VL, standard blade VL, to do pure VL, pure DL, or video assisted DL, and you get more blade time as I'm training you when I actually can see what you're doing. Because otherwise it looks like this, you put the laryngoscope in and I'm like, what do you see? What do you see? And it's like, I see pink. Okay, pull back. What do you see? I still see pink. And then the baby desats. And then now I have to take over the airway, right? And I don't want to do that because I want you to have a full learning opportunity. So I find that I can better teach you this way, build up your skills. And then now the next time we're together, I'm going to go, okay, now you're going to use VL as DL. So you're not looking at the screen, I am. Okay, now we've graduated past that point. Let's go ahead, pick up DL. Okay, but I find that this is a better teaching technique. And most of our residents will say, wow, I actually got a lot of blade time and I intubated that 2-kilo baby. Yes. Genius.
So, in your experience, do you see any difference between the CMAX, normal geometry blades and hyperangulated blades? Another question was, It's a great time to ask inpatient residents some surgical tendings to think through how to do a trach emergently. Is it a great? I mean, we're not exactly sure what the exact question is, but I guess
Front of neck, yeah.
I guess it's about the teamwork for emergent trachs.
Yes. So two great points. So first, the first one, do I see a difference with the non-standard blade geometry blades compared to the standard blade ones? And yes, it's a different technique. For those that were present in the workshop this weekend, you got to practice and actually feel why that's different in babies. You know, glide scope, we all learn how to use that in standard, you know, in residency with adults, but you have a lot of room and a lot of airway lumen to work with. In a child, particularly one with craniofacial differences, underdevelopment of the mandible in particular, you have very little space to work with that hyperangulated blade, okay? And so it's important to kind of challenge what you normally would do and not aim for the best view initially. Actually aim for a 2B view, okay? That way, both your blade and your styleted tubes see each other, and you can do this more incrementally. And I believe that that's the trick to hyperangulated blade VL in children. And that's why we are less successful with that technique in children and infants compared to standard blades. So that's that comment. And then regarding the front of neck access, yes, emergent tracheotomies. So our ENTs will tell us, don't, you know, in a small child, technically less than 8, especially less than 2, you know, if you're going to do front of neck access, don't go for a crike because it fails. Okay. It's not only the horrible complications, of course, that we're, you know, trying to prevent, but it has a high failure rate. You're much more successful to actually do exactly what you would be doing, but doing it at the trach level. Okay. And more data on that to come by other investigators.
Okay, great. Well, thank you so much. I mean, it was a
you.
great talk and very informative. And thank you for sharing your studies and the studies of your colleagues. And highly informative, very impressive. Thank you for being here and sharing your experience and expertise.
Why, thank you for having me. Thank you so much for your time.